Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome to the podcast. Today, I'm thrilled to have two incredible experts with me, Kristen Keech, occupational therapist, and Jessica Asiello, occupational therapist. Together, we'll be diving deeper into the complex world of disorders of consciousness, unpacking the latest research, and sharing practical strategies you can start using immediately. Welcome, Kristen and Jess.
Hi, so happy to be here. Thanks for having us.
So excited.
I'm so excited to learn more about you because I really don't know too much about you two. I was watching your course on MedBridge and I was like, oh my gosh. Just was so excited about today. Could you get us started by sharing a little bit about yourself?
Sure. So I'm Kristen Keech. I'm an occupational therapist, as JJ mentioned. I've been an OT for about 14 years, primarily practicing in acute care, recently branching out to be an adjunct instructor at the first OT program in Hawaii. And I just really found a passion for working with folks with disorders of consciousness, which we'll get into a bit later in the podcast.
And I'm Jessica Asiello. I'm based outside of Boston, and I'm also an occupational therapist. So thrilled to be here today. My primary role right now is in academia. So I'm an assistant professor at the MGH Institute of Health Professions. My clinical practice is in acute care, and that's also where my research is based as well.
Outstanding. So tell us a little more about what attracted you to disorders of consciousness specifically, and kind of how that passion evolved over time.
Sure. So my journey with disorders of consciousness started early on in my career at Mass General Hospital. I had a specific patient who was deemed to be unresponsive, but I had the opportunity to work with this individual. And for me, it was the thrill of seeing a response. So the fact that everyone else around me was like, no potential, they're not responding to anything. And I would go in and their eyes would pop open with my interventions and they would respond to their family member's voice. It was just so, I don't know how to describe it, like so inspiring. And so it kind of motivated my passion to move forward and advocate for these folks who can't advocate for themselves.
Oh, I totally get that. And isn't it amazing though? Everyone says, no, there's nothing that can be done, and then you are seeing that potential. So that's really impressive. So what about you, Jess? What do you want to share?
Sure. So like Kristen, I also started seeing people with disorders of consciousness early in my career, also at Massachusetts General Hospital. Kristen and I have a lot in common in our lives, but we joke that we somehow didn't meet until a little later in life. We didn't overlap at the time there, but I'm so grateful that I started my OT career at MGH because I had amazing mentorship from the OT department, but also from the interprofessional team there. When I started on the neuro service, everyone was so collaborative, including the neurologists and the physiatrists. And I think it gave me an excellent foundation in these best practices for DOC that we'll be talking about in the podcast, like the importance of doing these systematic repeated assessments on patients. And a little later in my career, I started to focus particularly on the cardiac population, working in those areas of the hospital. And I was so grateful that I had that solid neuro foundation. I know it sounds really obvious to say this sentence out loud, but I really realized how interconnected the cardiovascular system and the nervous system are. And particularly started to see a lot of DOC patients who had brain injury secondary to cardiac arrest. So people who had arrested and were resuscitated and had return of spontaneous circulation, but unfortunately in the process had sustained a hypoxic brain injury. And I felt at that point in my career really empowered that my voice and the voice of my fellow therapists, the PTs, the speech therapists, we really brought a lot of those best practices into that service of how to apply the latest guidelines and systematically assess people with disorders of consciousness, because the rest of the team, while still very collaborative, understandably, those cardiac specialists just aren't as in tune with looking for neurological issues and not as up to date on some of the evidence-based practice guidelines. So that was a point in my career where I felt even more passion for the DOC population, because I really saw the value that me and my therapy colleagues were bringing to the team.
Isn't it so amazing? I mean, it sounds like MGH was just absolutely stunning for the whole collaborative component. But then you're right. I mean, in school, they divide out neuro and then cardiac, and then, so they divide that out, and then you see it all meshed together when you can really have interprofessional work. I just think it's so exciting. Yeah. So when you guys, your passion is obvious with this population, and it makes complete sense in regards to what you guys have seen. What do you think are some of the biggest misconceptions about disorders of consciousness, and like what types of questions should we be asking as clinicians in regards to that?
That's a great question. I think one of the biggest misconceptions I've noticed is realizing that there's potential. That's a huge one. There's potential for functional recovery if we take the correct approach. And we should also really question if we know the difference between consciousness and arousal, because those are two very different things. So we should be looking at those definitions, what they mean, what they present as, thinking about, are we setting these patients up for success? Are we setting up the environment, eliminating any sort of stimuli that might interfere with their ability to respond to what we're asking them to do? Are we giving them enough time to respond? I think many of us have seen in the clinical world teams going in and say, thumbs up, 2 fingers, smile, open your eyes. Oh, nothing. When in fact, we should be giving them a substantial amount of time, knowing that there's likely a processing delay in their ability to comprehend what we're asking them to do in order to get the most accurate assessment. There's a lot of components that go into it. And are we educating the team members? So interprofessional collaboration is huge with this population. It cannot be a single individual discipline. It has to be a team effort in order to get, like what Jess said, these assessments over time, standardized assessments, and really get a comprehensive picture of the performance of this individual across the span of the day, the week, the admission, to really find these small successes, if you will, or these small responses that are indicating that there's progress happening that may not be obvious to, the neurobehavioral assessment at bedside every time. Educating them on clinical practice guidelines. We have these teams who are talking about withdrawal of care within 48 hours of someone with a brain injury. It's, if I can be blunt, it's terrifying, right? Yeah. So I think for me, I took on the responsibility of advocating in a way of introducing teams, especially these consulting providers, on the importance of early rehabilitation consults. So we're talking across the board: physical therapy, occupational therapy, speech therapy. And while to a bystander, it may look like a similar approach, we're all working towards different functional goals. And along those lines, are we making these goals realistic for this individual to achieve? We shouldn't be going in their first day writing goals for independent with ADLs, right, within 10 visits. That just doesn't make sense when you think about it. And so we really have to break it down by their ability to respond to different multisensory stimuli to show, like, look, they responded 1 out of 4 trials to an auditory stimuli on this occasion, but they responded to 3 out of 4 times on this occasion. So it's showing that, not necessarily active participation, but that increase in responsiveness that could potentially lead to functional recovery down the road and a pivot towards more a functional approach, if you will.
Okay, so I have to, there's just so many great things in what you just said. But first, I just really want to emphasize, because I think this is so important, and it's so hard for me, and I don't think I have emphasized it enough in the past when I've even lectured, but that whole giving your patient time to respond. Mm-hmm. And you're right, like the doctors come in, this, and I'm like, what'd they just say? Like, I might not have heard that, but how long do I do I wait? Like I give a cue and then how long do I wait?
So when we're talking about the same multisensory stim, so there's very much like a hierarchy that you go through. So we'll just use auditory because that's the example I've been using. You typically want to wait 10 to 15 seconds in between each command. Okay, so if you're saying, look at me.
Long time.
Pause, and then deliver, look at me again, right? Keeping it simple. If you're transitioning from one sensory stimuli to another, for example, auditory to visual, you want to take about a 60-second break in between. Wow. So there's a lot of pausing happening, a lot of observation happening. So for example, before you even start your assessment, you want to just stand out of their visual field and just observe for at least a minute and see if you're noticing any spontaneous or purposeful behaviors that you're not maybe getting in your examination for multiple different reasons. Maybe they're cognitively fatigued. Maybe they've already been overstimulated throughout the course of the day. Maybe they have a fever. We have to take all these things into consideration and work towards addressing them as a team, right? Because OT has a specific silo, PT has a specific silo, doctors address the medical needs, but that doesn't take away from the fact that physical therapists and occupational therapists can make note of these potential confounders, we'll call them, or complications, and make the team aware that it's happening and they're observing it. So that way we can address them as a whole and kind of eliminate these confounders and give the person the best chance to respond to what you're asking them to do.
Yeah. And we know that all of these things can fluctuate a lot too. So if PT sees somebody at 9 a.m., OT sees them at 3 p.m., they might have different exams or one day to the next. So it's important to be consistent and also document what those potential confounders would be. Document things like the time of day or aspects of the environment or positioning at the time of your exam for those reasons.
That was what I was just going to say. So first of all, thank you for giving me like some kind of framework, because I do think this is one of the hardest things. Maybe I don't think I'm alone. And in regards to paying attention to how long are you pausing and giving them a chance to initiate before I just go all up in there and start moving and then say their max assist to 2 or whatever. And that other piece about documenting, being clear, like once you find something that works or what time of day, being, more specific, and correct me if I'm wrong, but being more specific in your documentation so that then the rest of your team, you can be on the same page and have more reinforcement. Would that be appropriate to say?
Absolutely, yes. The important piece is we're having these collaborative meetings, right? Hopefully daily rounds are happening. Hopefully family meetings are happening, which will emphasize how important it is for the family to be included if they're available as a member of the team. Because I can't tell you how many times I've noticed a family member sees something purposeful, a smile, tears, some type of vocalization that the team does not. And oftentimes they can be kind of brushed off and saying, oh, that was just... So I'll get to that a little bit more as far as our interventions go later. But I definitely think, again, emphasizing that team collaboration and team effort cannot be emphasized enough.
Mm-hmm. Okay. Sorry, I was getting excited. So
I love it.
So Jess, did you want to talk a little bit about like the recent research and give some important, like highlight some of those takeaways for us?
Sure. I think that's a big takeaway for this population is that there is so much active research happening, so many new updates, like even since the time that Kristen and I recorded our first MedBridge courses last year. So that would be my number one advice to anyone listening is stay on top of the evidence because it's rapidly changing and some really interesting and exciting findings are coming out. There's 3 main takeaways from the research that Kristen and I wanted to highlight today. One is around functional prognosis. So that's always the burning question everybody has, right? Family members that you're trying to educate or even colleagues that you're brainstorming with. What is this person's future going to look like? And we do have quite a few large cohort studies now demonstrating that if people get access to the right level of multidisciplinary rehab services and the right medical care, much higher percentage than perhaps we were previously biased to think, can attain functional independence in the long term. Some of these studies are showing 60 to 80% of people who initially might have been unresponsive in the long term may regain functional independence.
That's great news.
It's very shocking when you think about those statistics Kristen was sharing earlier about withdrawal of care. the number one cause of death in the acute phase in disorders of consciousness is withdrawal of care. So is that happening to people who are misdiagnosed or perhaps being given up on a little bit too early? It's a really big ethical challenge. So something that we need to be keeping in mind. And that leads to the number two big point we wanted to make today, which is if you're working with this population, you must read the Disorders of Consciousness Clinical Practice Guidelines. These were published in 2018. So they've been out for a few years now, but it always takes time for that evidence to trickle into practice. And we hear a lot of therapists who are not aware of them. So must read. It's an open access article. So if you just Google Disorders of Consciousness Clinical Practice Guidelines, it'll come up and you can access the full paper. It has a very comprehensive list of recommendations that cover all of those great points Kristen was just speaking about in her response earlier. Some really important ones that we emphasize are the gold standard standardized assessments and using them systematically across the whole team, and avoiding those prognostic conversations until after day 28 post-injury is actually one of the key guidelines. So that's a really important one to keep in mind for those in the acute care setting. If it's still early since their brain injury, you shouldn't really necessarily be making broad statements about prognosis at all, because we know now from a lot of research that it can take some time.
Okay, so, oh my gosh, I just want to, this is important enough, I think, that we can try to make sure we include it in the show notes.
Mm-hmm.
And then just back to the education piece, if they're saying, okay, after the second day, withdrawing care, I think, therapists, we feel helpless, but this is what you go to. Make sure, if you get this or have your student read it, utilize these points, right? To make your argument and to stand up for your patient and to make sure, because, wow, that's interesting. So you're saying 28 days, you should wait until you're making a strong prognosis, because you could be setting someone up that isn't going to show progress.
That's the public guideline. Yeah.
Yeah. That's amazing. Okay.
Mm-hmm.
That's great. But that's great. Not that point, but the CPG for therapists to utilize to help back up when they're fighting for their patients. It's so great to have evidence to help you do that. That's really exciting.
Oh yeah. Print it out, highlight it, hand it out on the unit.
I've done it. I've sent emails to chief of trauma. I've gone that far where I just sent a cold email, unsolicited, just to try to start that conversation, right? And you have to kind of get out of your comfort zone with this population. And I think your confidence comes with more exposure, right? And kind of educating yourself on what's available out there. But yeah, I've definitely sent emails with the practice guidelines attached and say, our approach needs to change. We need to work together to get these early consults, to get a more comprehensive assessment. To one point I missed was facilitate alertness and arousal. If we're not attempting to wake someone up, how do we know that they're awake enough to respond to what they're, And so we'll talk a little bit more in the podcast about what these strategies involve and what you can utilize as therapists, but really as any clinician. This is an interprofessional clinical practice guideline paper. So it's meant for the whole team. And there's definitely some ones that you can pick out specifically that help us as rehab professionals. But there's been a multitude of research coming out on what we can do as rehab professionals within our scope. And how we can approach that and justify it and advocate for these folks, like Jess said, to get the right amount of medical care, but also that post-acute rehab.
Yeah.
It probably a lot of our listeners will think wow, I haven't really had anyone that gets into acute inpatient rehab. It's possible. I've done it. You might feel like a little fish in the big sea, but keep that passion, keep that fire, be persistent. And I promise you, speaking from experience, you will get these results for these individuals who may not have had it if you weren't involved and you didn't work so hard to inform yourself on what the literature and research is saying.
Yeah.
Stunning. Now, Jess, I interrupted you. So did you have more points?
Oh, no. I mean, that's a big take-home point. So I think it's an important one to emphasize. Advocacy is in all of our scopes of practice. So that is something everyone on the team needs to be doing. And on that note, the third new piece of research we wanted to make sure to highlight today is really a big push for new studies coming out recently in the population of what's now being called covert consciousness, or sometimes called cognitive motor dissociation. And in this circumstance, these are patients who, on a bedside neurobehavioral exam, are not showing any signs of consciousness, so unresponsive. And yet when advanced imaging techniques like functional neuroimaging or EEGs are performed, we're discovering a subpopulation of those folks actually are conscious. It's that their brain injury has just caused such a severe disconnect between their cognition and their motor functioning that they're appearing unresponsive when in fact they are conscious. And that's actually a new study that came out even since our MedBridge courses that went online last year. This past summer, there was a big study that came out from our colleagues at MGH in the New England Journal of Medicine, and then also got picked up in the New York Times, so it's been in the news a bit. They found 1 in 4 of the unresponsive patients in this multi-site sample had covert consciousness. So these were folks who were completely unresponsive. If you're a therapist doing the coma recovery scale or a bedside exam or providing bedside multisensory stimulation, you could be following all the best practices and the person's not responding at all. When the researchers put those people in a functional MRI and did advanced EEG techniques with them and gave them functional motor tasks like imagine opening and closing your hand, now stop. And when they could see the results in the fMRI and the EEG, 25%, 1 in 4 of those people that you might be writing off as unresponsive are actually fully conscious and cognitively functional. So kind of, ethically challenging, scary to think about, but such an important thing we need to be aware of before we're withdrawing care.
Wow. I haven't heard. So covert consciousness or cognitive motor dissociation.
Yep.
Those are the terms that you might hear. Mm-hmm. So do you document? You can't, right? So what happens? It's just more of educating those around you that this is what the study said and this is what could be going on.
Yeah, you got it, JJ. That's exactly right. So it goes back to that advocacy piece, which is in everyone's scope. I know some therapists listening might be saying, oh, well, I can't order an MRI or I can't order an fMRI or an EEG. But you can have a dialogue and advocate with the interprofessional team and with the physicians and print out those guidelines and show them to them, print out the study and show it to them and have a conversation and be the advocate for your patient, because we know that this is a really vulnerable population that is currently not getting the best practice care. So I think it's everybody's role to be aware of this evidence and speak up about it.
It is exciting. You're right. There's a lot of new things coming out that I didn't even realize.
Yeah, especially when you think about like brain-computer interface and like types of alternative communication technology. There might be really amazing ways in the near future where we can really reach those people with covert consciousness and find ways to help them communicate with technology, which is really exciting to think about.
And I think, too, if I can just add to that, I know there's a lot of facilities out there that don't have access to this type of technology. Mm-hmm. And I'll use my facility, for example. Here in Hawaii, we're geographically isolated in a way. We don't necessarily have all the resources we need, especially when it comes to post-acute rehab. We only have one facility that's an IRF. So for me, some of the kind of key pieces of assessment I look for is vertical eye movement. So when you look at folks with locked-in syndrome, typically vertical eye movement is preserved. So if you don't have access to this advanced imaging or these kind of tools, I encourage rehab professionals and other clinicians to use that as a command to see if you're getting someone a response in that way that, again, you may not see in these standardized assessments because that is not included, right? And I think, too, the important piece of realizing if some of these folks are truly conscious and cognitively preserved, please be mindful of how you're talking about that person around them, right? Because we truly don't know what they're hearing, what they're comprehending. So I always encourage the whole team, whenever you're repositioning, moving someone, explaining what you're doing. And that's another really critical piece. I could go on for days, as you might have realized, but the importance of communicating what you're doing in the event that this individual is more conscious than maybe is perceived on a bedside assessment.
I think those are excellent points. And just real quick, because you kind of moved into like translating. I'm always about the translating into the clinic part. But now I'm curious. So the vertical eye movement so someone with locked-in syndrome still has vertical eye movement intact. So
Correct.
how do you, either of you, usually assess this?
So usually we start with facilitating alertness. So making sure eyes are open, they're vertical, and then moving towards look up. Look up.
So
and
you just
using that simple command, look up.
Mm-hmm.
That's it. That's like typically what I
one.
Yeah, I was like, oh, okay.
I would say one other tip
I
is
didn't know if you used more of visual, like visual cue, or if you just use more of an auditory cue, or
that's a great point.
both.
yeah, a lot of
Right.
people have aphasia and you might not realize.
Geez, Jay, this is pretty straightforward.
No, it's a good question because that is something else to be aware of because of the brain injury. Somebody might have aphasia and you don't know because of their disorders of consciousness. So a multimodal approach is always a good tip. So yeah, starting with the verbal lookup command, but certainly like introducing an auditory stimulus or a visual stimulus to get them to look up. So that's a great idea.
That's a basic. I just didn't know if there was something super secret that you guys could share with us. So, all right. Well, this shows you how much I know in this specific area. This isn't a population that I obviously have worked with a lot. So I just find this absolutely fascinating and I'm very excited to pass that along. So give us more. Like, we're translating this great information into the clinic. Like, are there certain patients? I mean, we kind of talked about it, but just let's build on that.
Sure. So when it comes to specific patients, unless there's definitive evidence that there's a poor prognosis or brain death, really anyone on this disorders of consciousness spectrum is appropriate, from coma to minimally conscious to emerging from a minimally conscious state into that kind of post-confusional, what we see typically is like that motor restlessness, that those agitated type behaviors is appropriate. So again, that's why I emphasize that kind of early rehabilitation consults. So we're getting in there early, we're kind of seeing what the baseline is, and then we're better able to utilize this evidence, create these interventions like multisensory stim protocols, verticalization, a lot of kind of these interventions we use, but just in a more standardized approach, if you will. So that way you're not just kind of going about these commands in a way that's not necessarily organized, but you're doing it in trials. You're, like you said, pausing in between. So it's really appropriate for anyone across the DOC spectrum.
Do you have anything to add, Jess, in regards to just what kinds of things we could translate, like giving us some examples of assessment or interventions or?
Sure. Yeah, there's a lot of great assessments out there. The one that's considered a gold standard is the Coma Recovery Scale Revised. And actually some new exciting research. Like I said, there's constantly new things coming out. There's a new version called the CRS FAST for accelerated standardized testing, and it's developed specifically for the acute care setting. So that's another tip for anyone listening. If you work in acute care or a setting where there's just logistical barriers to do the full standardized assessment, which can take a lot of time, this new CRS FAST version is wonderful because it takes about a third of the time to administer, about 6 minutes.
So CRS FAST is what you're saying?
Okay. Yep. Mm-hmm. And let's see, what are some other good tips? I've heard a lot of my PT colleagues getting really interested in the new research on verticalization. So using the tilt table, not just for, hemodynamic adjustment to being upright, but also as a mode of stimulation. So when you're upright, you're weight bearing, right? You're getting that proprioceptive input. You're getting the vestibular input of changing positions of your head relative to gravity. So using the tilt table as actually a form of cognitive and sensory stimulation, there's some cool research about that is definitely where PT colleagues can take the lead as well.
And it seems that, so if you're documenting well, like Kristen, when you first go in, just stand there a minute and just kind of observe, get some baseline, be specific with how they respond to your cues. And it seems like it would be really nice comparison to then if you get them sitting upright or you get them up in the tilt table to then use some of those same cues so that you could document and compare and show people that, getting them upright. We always try to teach the students, right? They're like, oh, they're they're not awake, so we can't move them. And it's like, that's when you want to move them, right? If we want to get them up, we need to figure out how to make sure how to do the correct handling to do that. But I think, there's this resistance with documentation, but there's also this priority of being clear with the documentation that there's always something to see, even if it's not compared to what we're used to.
Exactly. So I think along the lines of documentation, I mean, we should be really structured with it as well. So I've worked with like the IT department at my facility and getting the coma recovery skill incorporated into our flow sheets. So it's simple as just putting in the score, and then it gives you the final score, and then you kind of use your clinical judgment to interpret that score. The good thing about the coma recovery skill is it's also free to access online, the whole manual. And Spalding rehab hospital was the one to come out with it. So they have some great resources on like how to go about training your staff and creating competencies to make sure kind of everyone's up to par on how to administer it and how important it is to stay along the script. Along those lines, I've often used language from the coma recovery scale to create my goals, my initial goals. So using the trials, and that way you're not, reinventing the wheel per se, and you have something solid and measurable. Now, I think that's where a little confusion comes in with clinicians who are less experienced. We're sometimes trained to make goals functional, and you can still make it functional, right? Like patient will localize to auditory stim 2 out of 2 trials on either side in prep for pick a functional task, right? So you can still make it functional and tie it into function, but I would be hesitant to create functional goals at this point in time if the patient's not ready for it yet. So think that, that 10 visit window, is that realistic to have them brushing their teeth in 10 visits? Maybe not. Have I seen it happen? Yes. But again, we want to think of what's realistic to that individual. And we really want to individualize everything. So I know, JJ, in some of the courses I've gone of yours, we talk about autonomy and individualization, and that still applies to this population. So again, bringing that family in and identifying what are some familiar sensory smells or sounds, music, anything that could potentially provide meaning to that individual that we can incorporate into our treatment sessions to make that a bit more individualized versus, again, using that blanket, look at me over here, or follow this highlighter, maybe using a picture of them with their loved one. Or their dog or whatever, that family member, hopefully that's at bedside, can help identify is a really, really key piece in the literature, even talking about the use of familiar sensory stim. So sure, maybe use the coma recovery scale to get a baseline of what they're responding to best. But in those upcoming sessions, really try to individualize it and work alongside the family. Have the family also make observations when you're not in the room. Because I think in acute care, right, we have a limited time. And oftentimes these folks aren't prioritized because they're considered too low level. Well, that's when we have to bring in other team members. It's a team effort, like I said, and I'll continue to talk about that. But, it can't be a sole discipline effort, and we really should focus on individualization nonetheless.
You know how that makes my heart so happy. And just it's thinking about like giving the family a chore, so to speak, to do because they just feel so helpless. Here on this sheet of paper, write down any of the things you see and what time, because even the time could make a difference. And walking to their room and seeing what pictures they have up and what are they, and thinking, oh, okay, I'm going to use coffee because everyone loves coffee. Well, Jay doesn't love coffee, so maybe chocolate, and that might wake me up. But so that smell. So I think this is just such a great point to just keep our eyes and ears open and take full advantage of that opportunity. It's just so important.
For sure. I mean, I had one individual, I used a can of Coke because he really liked Coca-Cola. And I felt cruel doing it because he couldn't drink the Coca-Cola and he had a level of awareness. But that's going to be much more meaningful than following a yellow highlighter back and forth. I mean, what does that mean to, I suppose maybe there's someone out there, a teacher, someone who really loves yellow highlighters. Again, you just really want to emphasize getting to know that person just as you would with someone who can communicate what they love and do. And one more quick point along the family is I often tell them get a notebook and do trials as well. So if you notice they smile to something in particular one time, try to reciprocate that, because that's going to advocate, that consistency is going to advocate that this is a true response to whatever stimuli you're presenting, not just maybe a random reflex. And that could be hard for families. So it's not a one and done. You're educating continuously throughout the continuum.
Have you ever recorded like a family member saying something and used it? Like if they responded to a family member saying something or a family member giving a cue and recording it? I don't know. I just was thinking that, that's just that familiar voice can make such a difference. I don't know.
Yeah, the smartphone's awesome now because you can have video clips from family members. So I've seen that before. Yeah.
Yeah, I've done that before. Definitely recorded like a short story about, let's say, their wedding day or the birth of a first child. There's, a lot of research that supports the auditory stimuli in particular, and having families read like a short story or telling a short story has been shown to be really effective. So I've definitely done that. Usually after the first assessment, I'll start to bring the family in more. That first assessment, I ask them to step out just to, they like to answer sometimes or try to get their loved one to answer, understandably. But then after that, they're part of my crew. Like they're coming in, I regulate it, but I like to include them because, like you said, it empowers them to then become the advocate. I can't follow that person beyond the hospital, right? I'd love to, and some keep in touch, which is wonderful. But, we need to empower the family members as advocates as well. And that's another important piece of translating that evidence and simplifying it in a way that's digestible to someone that is completely and utterly overwhelmed by this dramatic change in their life, right?
Yeah.
So, Jess, let me, can I ask you? So,
Sure.
What should clinicians consider when addressing these perspectives? We've talked about some of these, such as patients and fellow care providers. And, are there any specific, and you've given some great examples, and I love specific examples, like specific points or word choices or strategies really to help promote the better carryover. Like example Kristen just gave, but do you have any words of wisdom?
I have a couple of examples. Just to piggyback off Kristen's point, I want to call out an amazing intervention she did at her hospital where she actually took all that caregiver education and put it into a standardized printout packet. So now every disorder of consciousness patient, especially if the family's not in the room at the time that you happen to see them for therapy, you can have that leave behind that has all those great tips she just described. And one more I'll add is like balancing stimulation versus rest. Sometimes you get those families that are like so excited to receive the education that they're like overstimulating the patient, and that can be really overwhelming and not as helpful. So that's a big part of the education point too, is if sometimes families need a good schedule or guidelines, like I'll say maybe at least once during your visit, do these stimulation activities, something like that.
Good. Be clear for them because they don't know.
Exactly.
And you always think more is better in general.
And then another key phrase I think about a lot with this population is participation. And so I'll share a story. Kristen and I presented some of this work a couple of years ago now at a national conference. And it was like this really eye-opening moment in my career because there was a Q&A at the end where clinicians started sharing stories from their own practice. And it became really clear how much disparity there is. So there were some people in the room who worked at, big academic medical centers that had these collaborative teams where the physicians were implementing best practices and they were doing all these amazing things that they were sharing. And then there were other people who shared, wait, so are you saying I can see these people? Because my manager tells me this isn't skilled therapy because they're not participating and this isn't going to be reimbursable. Or I go to the bedside nurse to see if I can see the patient and she says, oh, they're not appropriate for therapy today because they can't participate. And I'm not judging these therapists at all. I'm so grateful that they were vulnerable and shared their stories because I know they're not alone and it's a common story probably.
Yes.
But wow, we all need to do better because these people have a right to access treatment, right? We know there's a lot of evidence that functional recovery is possible. That trajectory can be very long. We know that misdiagnosis is common, and now we have this new study showing that like up to 1 in 4 of those patients that are unresponsive perhaps are fully conscious. And so you're saying they're not participating, but what does that really mean in somebody with a disorder of consciousness? What does participation mean? Are we letting our own biases get in the way? And to just blindly follow, probably well-intentioned but incorrect guidance from a manager or a colleague I'm going to take it so far as to say that that's unethical and harmful. Like we have a duty to be up on the latest evidence and to do our best to advocate for these patients. So it was a real takeaway for me that I think it's a little bit related to like confidence and self-efficacy. And that's my big passion as an educator and a clinician. I really want to empower therapists. So know that this is skilled. Everything you're doing is skilled. The caregiver education, the standardized assessments, the advocacy within the team. So have confidence, know those clinical practice guidelines, and feel confident being grounded in that language. And if you get pushback from a manager or a colleague, just flip that around to be an opportunity for education and for you to be a leader.
I love that. I think, even just neuropopulation with people who are like awake, they underestimate what they're able to do, and we don't push them hard enough. And we're always comparing to the standard. If they can't do this, then I can't work up with them. And so we have to look in the framework of what is this person able to do? And I just think that's well said. And with the tools that you guys are providing in regards to how do you document better? How do you give them more time to respond so you have better, results? And how can you use the clinical practice guidelines? I think you guys are giving some really great ideas. I don't know if those were your actionable takeaways. Sorry, they were I was so excited. But what would you guys say is your top 3 actionable takeaways, just so we can reinforce that to our clinicians who are listening?
So first and foremost, like I mentioned earlier, you always want to address the patient's positioning in the environment, even if it takes you extra time to do so. So you go in, you do your baseline observation, like I mentioned, but it's in the best interest of that individual to get them upright as is medically safe, and address any sort of stimuli that may be distracting and get them in a good, comfortable position before you start your assessment to give them the best opportunity to respond, right? We've reiterated this throughout, but familiarize yourself with those clinical practice guidelines. So I have gone as far as citing them, red, bolded, underlined in my notes themselves, just to really, because I think a lot of clinicians on here probably would be like, oh, no one ever reads my notes, but that's why I just go the extra mile and, bold and highlight everything. But I've gone that as far as that. And like I said, sending cold emails to consulting providers to initiate those conversations that can somewhat be intimidating, but must be done. Involve that family from day one. So the family should be part of your team if they're available. I know we have some individuals, unfortunately, that don't have a social support system. So you kind of work with what you have, but incorporating the family into the plan can have a greater impact on the patient's outcomes and responsiveness and advocacy efforts to get them to that next level. And of course, go ahead and do yourself a favor and watch our MedBridge course series on DOC. Like Jess mentioned a few times now, it's relatively up to date. There's a few, few new articles that have come out since then, but we really incorporated and talk about how to use those clinical practice guidelines effectively as a clinician and what the research is saying about best practices for assessment and interventions.
Yeah, I'll double down on that. It was really, really well done. So
thank you.
Thank both for that.
Thank you.
So we have a couple minutes left. I was wondering if there was a case. Like, could you give us an example of a hypothetical that you could kind of walk us through of what you might do?
Sure. So I'll use an example of a young individual who sustained a traumatic injury and subsequent hydrocephalus. So you're talking about swelling, needing a VP shunt. So there's some complications associated with, right? And they've been deemed by the team, say, to be unresponsive. I may elect to go in with the physical therapist to collaborate getting this individual to a tilt table or to a supported standing sling if hemodynamically appropriate. After my initial assessment, right, and talking about the coma recovery scale and kind of getting a baseline of what the response is, I'm now incorporating the family into those future sessions. So say we're going in for this next session, we did our minute-long observation. We set up the environment, transition this individual to the tilt table for some weight bearing and to increase alertness. I'm then incorporating some level of familiarity. So for example, let's say this person's engaged and them and their fiance have a meaningful song. Okay, so we can use the tilt table for this, or we could even use a standing sling. So when you have two skilled therapists, you can have the physical therapist helping to facilitate weight bearing through the lower extremities, stabilizing through the lower extremities. The occupational therapist is working on head and neck control. And then you bring in their loved one to engage in a dance that you can help facilitate to a meaningful song between the two of them. And maybe you're seeing some purposeful behaviors like tears coming out of that individual's eyes. And that right there tells you it's powerful, right? Because you know that, maybe they're not responding to say, take this cup, but you play a song that means something to them and facilitate closeness with them and their loved one and facilitate this kind of weight shifting. So you're getting a lot of neuromuscular benefits, cognitive benefits, but it means something to that person. Mm-hmm. And so you're seeing this very powerful response in them and saying they're awake, they are in there, they are feeling this. It almost like brings me to tears thinking about a hypothetical situation, but it can be compared to clinical experiences I've had personally, and it just means so much to see that response in that person, and then the reaction from their loved ones as well. I mean, it's hard to describe, but it's so important, that piece of familiarity when you're thinking about your interventions.
Well, and really, what are you giving them? Hope, right? Mm-hmm. And I think that might be the word you're searching for, but, because you are. And I think I love that example for just another reason I just have to throw in there is that in the beginning, this person is going to need to transfer. And the best way to get them is to be weight shifting back and forth. If we start incorporating that song into a transfer every single time, then we're reinforcing that and giving them something pleasant to think of and not just thinking of the end in mind. So I just love that all ties together. And Jess, I have a minute. Did you want to talk about someone? Because I'm just like,
oh, I'm happy to. Yeah. I have one person that always stands out as really like practice changing in my perspective on this population. And it was a young father who had had a TBI, and I met him in the neuro ICU. And his wife was caring for their young kids and working, and so she often wasn't there at the time of therapy. But I did a lot of caregiver education, leaving handouts behind for her. His mom was sometimes there, so I would do all the education tips like Kristen was describing with her. The entire time I worked with him, he was completely unresponsive. So all my therapy sessions, all this caregiver ed, but he didn't actually show purposeful movement or purposeful response to stimulation while I knew him. But the reason he's remarkable to me is because many, many, many months later, I was still on the neuro service, and I got a new consult for a cranioplasty patient. And it had been so many months that I didn't make the connection when I was chart reviewing, but when I walked into the room and saw his face, oh my God, it was the gentleman I had worked with all those months before who was completely unresponsive the entire time I knew him. And of course, he didn't remember me, but I was like, how's your mom? How's your kids? He was ambulating with a cane. He had aphasia still, but he was extremely functional in his communication. He was smiling, showing me pictures of his kids. And that was very moving to me, because you can read these research studies on a piece of paper, right? And see, oh, wow, there is a chance of functional independence. Oh, wow, the trajectory of recovery can be really long. But that was the first time I really saw it with my own eyes. And as an acute care therapist, I love acute care, but I do think sometimes that's something tough. We don't always get to know how our patients' stories end. They're with us during this acute phase of their injury, and then they go off to rehab or go home, and sometimes we don't know the long-term outcomes. So to see him come back and to see how amazing he was thriving after being completely unresponsive for a long time, really, I just always keep him in mind now. Every time I work with somebody who's unresponsive, you never know. Their functional recovery is possible.
That's a beautiful story. I mean, yeah, your acute care therapist is just so tough. And that's just really touches my heart and is very exciting. And so hopeful, I think. I want to end with that thought. But so to wrap things up, what final words of wisdom, inspiration? I mean, you just gave so many in those two stories. But anything else you'd like to leave with our audience?
I would say that embrace the unknown. It's okay to not know everything. All right. So know your own limitations. Don't be afraid to seek mentorship. Hopefully we gave you some really good pearls here today that you can utilize to bring up your confidence and engage in these advocacy efforts and best practices and advocate to your team to do the same. Remember that different individuals have different needs and wants, right? So that individualization, the autonomy is really important. And just staying up to date, as Jess mentioned so many times, on what the current research is saying, it will really help you to become your patient's fiercest advocate. And in the long run, not to sound dramatic, it could save someone's life.
Yeah.
Jess, any final words?
Oh, Kristen, you just summed that up so beautifully. It's hard for me to follow that up. I agree wholeheartedly with everything you just said. And I guess I'll just end on the note of, be confident. You got this. This is a really challenging patient population, probably one of the most challenging ones out there that you might encounter. And you got this. You're skilled. You've got the evidence. You can do this, and you can make a real amazing difference in people's lives and their trajectory of recovery.
Oh my goodness. Well, that wraps up today's episode. Thank you so much, Kristen and Jess, for shedding light on the disorders of consciousness. Let's continue to push boundaries of care, right? So we'll see you next time. Thanks again for coming.
Thank you.
Thanks, AJ.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.